Hi folks, I know everyone is as keen as my puppy to do lines, but you have to watch the video first. I won't spend too much time on indications, contraindications and consent. That will be done in tutorials later on. But for now, just concentrate on absorbing the general principles that you can see practiced in this video. The indications and contraindications are above, but again, don't dwell on them too much. The first thing is to ensure that you have everything to hand. We have central line specific trolleys which have green legs and a silver top. When they are clean, they have a green sticky label on them and they are good to use. It is your responsibility to clean the trolley. You will need a CVC pack and the relevant line from our storeroom. There are two different sizes of lines depending on which side you plan to insert it. In general, we use 16 centimeters for right-sided approaches and 20 centimeters for left-sided approaches. We avoid using the femoral access route except in the most extreme circumstances. Please note that on the back of the line packet is information about the line flow rates, and more importantly the device tracing stickers which then need to go in the notes. The CVC packs contain non-sterile hats outside of the sterile interior but do not contain a face mask or sterile gloves. When you open the pack, this is what you should find except for the line and sutures. You can get the lines, sutures, self-sealing bungs, gloves, masks in the ICUA storeroom. Note the infection control documentation which you fill in and place in the CVC box located in the nurse's station. There is also a sticker in the pack designed to make your life easier for when you document the line insertion. The storeroom is laid out for the stock team and there is a key on the wall. If there is something you can't find, please ask. Otherwise, look for the relevant item in the drawer number and hey presto. Please remember, it is your responsibility to organise the kit, not the nurses. If you need anything and you can't find it, please ask, but don't expect them to have everything laid out and wait on you hand and foot. After the appropriate consents, we are going to insert a right internal jugular CVC line in our mannequin. We are going to insert a 16 centimeter line, given that it is on the right, and just to be clear, we are going to put it in the big clear tube next to the big red tube. In our mannequin, that is. If you haven't figured it out already, the big red tube is the carotid and the clear tube is the internal jugular. This is what you should visualize when you look at the neck in the supine neutral position. Sternocleidomastoid divides into two heads which fuse with the clavicle. The external jugular crosses the posterior border of it and immediately you can palpate the carotid. The vein lies between the two. You can expect anatomical variation in about 10% of cases, but the anatomy will also vary with where you scan in the neck. Your approach may be high, mid or low, depending on the anatomy you find on that scan. Always do a pre-scan to identify the anatomy, no matter what you are doing. Here the vein is compressible and the carotid is pulsating and non-compressible. Just to reiterate, always have a plan, always do a pre-scan, always know where you are going and what you are going to do. All our bed spaces have dedicated hand washing sinks. Please use them. Hibby Scrub and Betadine are available on the unit. Please use them. If you have an allergy to one or both, let us know. You must always wear a face mask and hat alongside the sterile gown and gloves. Organisation is key here. If you haven't got your feng shui right, you will not be in the right frame of mind to undertake this task. Please make sure you lay out all of the equipment and ensure that everything is there and that you have an assistant. Please take time to check the equipment and make sure that it works. You will need sterile saline. It isn't in the pack and you will need help to open and dispense it because there are no gallipots in the pack. Make sure you have done your lock zip and that it is safe and appropriate to insert the CVC. Lay out your equipment, attach the self-sealing buns to all the lumens except the brown one. Flush all the lumens of the line. Hold the syringe vertically so that you don't flush air bubbles into the catheter. The purpose of this is to make sure all the lumens are patent and to expel any air in the bungs and the line. It is simpler to attach the bungs now and clear the air rather than do it later. The skin is always cleaned with 2% chlorhexidine with the enclosed applicator. There is only one in the pack, but there are more available on the unit. One coat is thought to be sufficient, but my practice is always to use at least 2 coats. Make sure you click the applicator to ensure you break the ampule inside it. Start in the middle of your field and in a spiral move outwards. Do not go over the same area with the same applicator. Leave it to dry and repeat. Use a new applicator this time. Always clean an area larger than the area you intend to drape. The drape has a sticky side covered by wax paper around the fenestration. The sticky side goes on the patient's skin. In the video I have folded it in half again to make it easier to apply. Remove the wax paper and dispose of it in a bin that you prepared earlier. Place the drape in the neck and unfold it. Press down to ensure that it is sealed. If it is not stuck down, just press it again. Now put the patient in a head down position and raise the bed to a suitable height for you. The key here is to be comfortable. If you are not comfortable, it will impair your performance and make the line much harder. Necklines and subclavian lines are done in a head down position for 2 reasons. One is to encourage venous filling to make it easier, and secondly it is to prevent an air embolus if a patient breathes in and generates a negative intrathoracic pressure which will suck air in through an open line. Please get your equipment ready before you start. It is easier to have it laid out in front of you in the order you are going to use it so that you don't have to keep turning or looking away from the procedure. Visualize the steps that you are going to go through. Make sure the sheath on the needle is loosely attached, and the same with the Seldinger wire. Getting the ultrasound probe cover ready is a job in itself. Think of it like getting a sock or a stocking ready to pull over your foot. When it has been rolled up, put your left hand inside it and add some, but not all, of the sterile ultrasound gel. You will need some later, and too much makes it awkward to handle the probe. Ironically, too much gel also gives a poorer image. Then take the probe from your assistant and secure the sheath with the bands in the pack. Once you have done that, check the probe's orientation. Don't worry if you've never used ultrasound before, we will teach you this. There'll be separate videos for you to watch and time to get accustomed to handling probes. Yet another confirmatory scan, and note there are no needles so far. We're just making sure that we can see our anatomy. Now it's time for our first needle. This is the local anaesthetic. This can be done much earlier, but that is for discussion another time. Before you start, go through your lock sip. In essence, check what you are doing, check you have the right side, that the equipment is correct, and that there is no contraindication or a reason not to proceed. We primarily use lignocaine for a field block. You can do a superficial cervical plexus block if you know how to, but we can also teach you that later on. Now for the trickier part. Approach the vessel between 45 and 80 degrees from the horizontal, and close enough to the ultrasound probe but not too close that you put a hole in the sheath. Once you are able to aspirate blood, then drop your syringe barrel down to less than 30 degrees, or roughly parallel to the horizontal. Here you can see the needle puncturing the jugular vein. If this isn't your first rodeo, then you will need to be assessed and signed off by one of us and follow the basic safety principles we outline here. Please don't use saline in the syringes when you're aspirating them. It doesn't help detection and may confuse things because when the blood is aspirated into the saline, it is diluted and venous blood looks like arterial blood, which may confuse you. It will also stop you confusing your local anaesthetic and saline syringes. With your probe hand, hold the needle hub, undock the syringe, cover the hub of the needle with your left thumb and take the Seldinger wire and make sure the cap is off and the J is within the guide. Never reverse the wire as the end is too stiff and may perforate or tear the vessel. The ECG must be monitored during the procedure. If there is any arrhythmia, stop, withdraw the wire and reassess. In the video you can see me clamp the wire with my thumb and advance my hand. I then release that and pull back on the sheath and expose 2 to 3 centimeters of wire, which then I clamp with my thumb and advance everything at once. You can use your thumb to thread this, but it will get tired. Clamping it is quicker and less tiresome, but it is optional. You can see that I have not let go of my needle and keep it rigidly in place. Once the wire is safely in, then the needle and the sheath are removed. As soon as I can see the wire emerging from the skin, I secure it with my left hand. Try not to let go of anything when it is in the vessel. If you do need to let go of the wire, place the free end in the sheath to minimize the risk of it moving or waving about in the breeze, which could lead you to desterilising it. Once the needle is out, ultrasound the jugular to confirm the wire is in the lumen of the vessel. Do both a transverse and linear scan. Make sure you haven't popped out of the front or the back of the vessel before you dilate it. Now take the dilator and mount it on the Seldinger wire. Note I haven't let go of the wire and I have controlled its floppiness by looping it in my left hand. That means I don't let go of it or put unwanted traction on it, which may potentially dislodge the wire from the vessel, even though there is a long length in there. The shorter end also makes it easier to mount the dilator. Before you pass the dilator through the skin, you have to make a nick into the skin using the scalpel in the pack. Remove the guard by pressing on the nubbin and retracting the sheath as in the video. Use a stab incision to relieve the skin. It does not have to be a massive hole, just slightly bigger than the diameter of the dilator to prevent skin traction. Once you pass the dilator, make sure you wait. You do not have to introduce the whole dilator, just enough to pass through the skin tissues and the wall of the vessel. The aim is to dilate the tissues and the wall of the vessel, not to ream it out. The tissues are elastic and they will spring back if you're not careful. As you remove the dilator, hold the wire. Make a loop again to control the wire and then load the CVC. Please note the gauze occluding the puncture site. That is to keep the field free of blood and preserve vision in the surgical field. Thread the catheter and don't forget to release the clamp on the brown lumen when you can't advance the CVC. Keeping the wire short helps you mount the CVC over the wire. Always control that wire as close to the skin as possible. Try not to touch the tip of the catheter just to minimize the risk of contamination. And then advance the wire until the tip comes out of the brown lumen and you can grip it in your right hand. Then thread the catheter with the left hand to the desired depth and remove the wire entirely from the CVC. Check the ECG as you do this. Make sure you occlude the brown lumen with the thumb of your left hand to minimize the risk of the air embolus. Remove the wire. Yes, we have had an air embolus on the unit, as well as a retained wire, carotid punctures, and also pneumothoraces. We are justifiably paranoid, before you ask. As soon as you can, put a self-sealing bung on the brown lumen. Here I have clamped the brown lumen with the attached clamp. That needs to be released as soon as the line is sealed. Before you suture the line in place, you must do a blood gas. Hopefully it is a venous sample. However, sometimes it's not. All lines must be aspirated and flushed before you secure them. If they don't aspirate, don't flush them. Just withdraw the catheter and repeat the aspiration and flush for all lumens. You need to suture the line in place with a 2O proline. Remember, it isn't in the pack, so you will have to get it from the storeroom before you start. When it comes out of the packet, it is concertinaed. To remove its memory, stretch it a couple of times to make it more manageable. In the video, you're about to see me tie a surgical knot onto the dilator. Don't worry too much about that technique, we will teach you that later on, but the reason is, if you tie onto the skin directly, you can cause skin necrosis, which will then lead to breakdown of the skin. That leads to loosening of the catheter and a local infection, which could also become systemic. The dilator allows you to create an anchor point without those complications. We use Proline because it is a monofilament, as opposed to silk, which is a polyfilament braided suture. The braided nature of silk means that there are nooks and crannies where bacteria can hide, which could lead to a bloodstream infection. If there is none on the unit, please ask theatres for a few packets and let us know and we will restock. Nylon sutures are inherently smooth. They require at least 6 throws to secure them, whereas silk, because it is braided, grips itself and only requires 3 throws. The other thing that you may note that I do in the video is to reverse the needle. The eye is designed to pass through the holes, and because it's blunt, this reduces your risk of needle stick injury. You don't have to do it this way, but I would suggest it may be helpful. There is a dressing in the pack. Please only use that one. Just lay it on the skin so the hub and the entry point are visible through the plastic. Make sure the skin is thoroughly dry before applying it, otherwise these dressings just don't stick. There is a 2-part butterfly clip in the pack which clips together and is then sutured as I described above. It is there to hold the catheter in place, but you still need to secure the hub as well as the butterfly clip. Otherwise the line will just run freely through it and will pull out easily with any traction. The only time you do not need the butterfly clip is if the catheter is inserted up to its hub, and then only that should be sutured in. Before you can use the line in ICU, you must have a venous blood gas and a transduced pressure from it. Thereafter, you must have a chest x-ray to ensure that the line position is optimal. The only exception to this is where the need for the line is critical and you have a VBG and a pressure chase. Then you must get a chest x-ray as soon as possible, but you can document in the notes that the line is okay to use in that specific circumstance, and that allows the nurses to start noradrenaline or adrenaline or whatever you need to go down that catheter in an emergency. At the end of the procedure, please account for all your sharps. It is your responsibility to dispose of them, nobody else's. Thank you very much for watching this simple introductory video. By now you must be as bored as my cat. If you have any questions, please ask any of the ICU consultants. There are more videos to come. Please watch them, and thank you once again for your time.